I'm Steve Pizer. I'm a professor in the School of Public Health and an economist at the Department of Veterans Affairs. And I'm going to talk sort of complimenting, and I'm going to try not to sprain my mouth as I talk, because I've got a lot here. I'm going to talk about the delivery of healthcare not through insurance mechanisms, which a lot of us are familiar with, but our healthcare system is a patchwork. And one of those patches is directly providing healthcare to people through public delivery, public hospitals, public clinics, and one of the biggest networks of those is the Veterans Affairs system. And this might be appealing when we're thinking about inequity, because the private delivery system has embedded inequities in it. Kevin talked about some of that. The private providers tend to cluster where more affluent, better insured people are. So there are different ways of trying to address that inequity. Federally qualified health centers is one, which Megan talked about. Public hospitals, county hospitals, veterans hospitals is another way. And some countries really invest heavily in that kind of public delivery system. Think the UK and the National Health Service. So those public delivery systems have the potential to address those inequities in underserved areas. But will they actually do it? For them to actually do it, they've got to put their resources where the resources are needed, and they've got to turn those resources into care for the public. If they misallocate their resources, it can be hard to fix because allocating resources are sticky. And management is difficult. It's hard to get public employees, hard to get any employees actually, to produce what you want them to produce. All right, I'm gonna move quickly. I'll take a minute here. So this is a supply and demand diagram. We're talking about economics and inequity. When we've got public provision of services, the government isn't necessarily selling those services. They're just providing them directly. So how do we think about markets for those kinds of public services? And one way we can do it is we can replace the price in a market with a waiting time. The waiting time works like a price. As waiting times go up, it puts pressure on providers to provide more. And if waiting times go down, demand increases. So if we monitor those waiting times, that gives us a clue about how to manage our resources. And I'm going to skip a lot of this because I'm running out of time. So we need to measure these things. We need to measure waiting times. We need to measure productivity and see if our resources are misallocated for that reason. Let's see. So there's some technical details about all this, which I'm not going to get into. But I'm going to skip ahead. So you can see in the VA system, waiting times are very uneven. You would think if resources were flowing optimally, that waiting times would be more even. They're not. The reason they're not is that it's really hard to move resources around for political reasons, for management reasons, for budgetary reasons. So what we want to do is invest in making those resources more movable, like virtual care, which has come up, and also holding management accountable to putting the resources where they're needed. All right, talk to you all later.